You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
I thought we forgotten who we are. Explorers, pioneers.
Alex inevitably gets into a very spirited conversation right before we start recording. And then when we start recording, he puts the microphone where nobody can hear it and just stops talking.
It's only when necessary.
So we have a special edition podcast. So your actual last day is when?
It'll be Wednesday next week.
And then Troy's picking
Wednesday next week.
Alex over here. But I'm leaving tomorrow for a trip. So this will be kind of close to the next day or last day I see Troy, doing his, last supper before death row, tonight. And he picked, Oak House. So I'm gonna have to get a loan to take him all to dinner tonight. And then we're doing a special edition because Troy Plus, right? With some listener questions. And then, so he has questions for all of us, or I guess the group, right? We'll all answer them, or if maybe one's specific to somebody. And then we all have a few questions for Troy. And yeah, we'll just see how far we get into this thing. And we're going to start mostly with Troy. And then if we get, like, he's got a couple left and we're running short on time, we'll get into ours for him too. So with that, any updates on anything? Anybody's life?
I don't know what the last episode was. What was the last
This is a podcast with microphones.
Last episode was a functional medicine. But
Well,
you did it so
No, you did
solo
one that was
concussion.
solo
I just did
concussion.
concussions. Yeah.
How's old tick lady doing?
I have no clue.
No idea.
No clue. Alex is going to Malta.
I'll be getting abs.
Yeah.
There's that.
Yeah.
Yeah, that's a
We
big
don't
update.
care
He
about
won
your
the
labs.
Xterra 35K
Mhm.
and a
People don't wanna know about your-
319. So it was like a 21 miler. It's a pretty good time for that.
Yeah, it hurt.
Yeah.
And then
I about died. I just,
Don't-
yeah, really the next day hurt. But yeah, paid for the race. If anyone wants to come, I'm taking applicants.
Yeah.
Don't talk to us about your labs. No one wants them.
Yeah.
I'll be honest.
We might discuss that. We already know what they're going to say.
I told Troy I've been waiting for the shipment for the lab kit to come in, and I went and checked the order status. They're not coming to me. I have to go to them
To where?
to Quest, Brookwood.
Well, it's a quest. I mean, it
Right.
makes sense.
Which
It's in the name.
I reread the email, and there was fine print. It said, yeah, if you ordered outside of Quest, then they'd be coming to you in 5 to 7 business days. But
We can talk about this. This is super entertaining for
and
everybody
they definitely
listening.
started the email with the first word he said. Yeah. So.
Yeah.
mhm.
All right. So let's
Read
get
the
into
fine
it.
print. Read
We're going to get Troy. We have no clue what these questions are. He doesn't even know what order they're in. You should have did a random. Like some
Yeah,
sort of-
I'm just gonna roll through,
Yeah.
see which one I want to ask.
Yeah.
But
Let's get it going.
yeah, so we got a bunch of questions hot off the press.
And let us know which ones are yours and which ones were somebody else. And if it's somebody you
Cool.
want to mention, go for it. If
Will
they
do.
wanted to remain anonymous because
Yeah.
the question's dog pile.
all that will be me will be ones I don't preface with the name.
Okay.
I'll give a shout out to those that come from a listener.
Sounds good.
Cool. All right. Without further ado, let's get it rolling. Let's see. So, beyond technical skill, what qualities define an exceptional MSK practitioner in today's healthcare landscape?
Whoever wants to start. We'll think about it. Give some dead air. I guess Riverside will cut this out, so we'll just go straight to the answer.
Does it really cut this stuff out?
If you do have a gap, yeah, it'll just. I mean, basic ones. So again, I kind of try to make fun of it when I teach, but like, don't be a dick. So you have to keep people around long enough to be good at your job because you could be the best in the world. Nobody keeps coming, and that could be for a lot of reasons. You're not very good at business, which could be you've hired other people to do that part for you because you're not good at it, or you yourself are pretty good at managing. So you got to keep them in the realm. Well, to keep them there, you got to initially get them to kind of trust you and be somewhat amicable. So it's basically just being not necessarily a nice person. So I heard a good definition by Matthew McConaughey the other day between a nice guy and a good guy. It's like a good guy stands for something, is willing to be a little bit gruff or have people not like him because he's like, well, if you're going to do that, then you can just leave. I think you got to be a good person. So what I mean by that is some people want to come in here and what we're offering is not for them. What they think we're going to give them doesn't match what they need, or they're literally not a good fit for you as a clinician. I think so. You need to be a good person, not necessarily a nice person, because you can just get steamrolled all day. And that's going to bug you and them. So yeah, I think that'd be one thing, is to be a good person.
I like that.
Except pretty broad, but
yeah,
you can get really
it is a broad
with
question.
that. You can get really specific with that, but I think that's one thing. Now I'll pick. So here, I'll try to get something that maybe people won't think of. Not playing off what I teach, but I literally think that a lot of people go through school, memorize all the stuff, go to seminars, try to learn how to do stuff, and then they get out into practice, and that's like how they operate, right? I learned how this is the way it is. I learned how to do this from my mentors, which isn't a bad way to operate. And they lack the ability to kind of think independently of what they're taught. And there's nothing wrong with that. So they go, you become an ART person, MPI, DNS, and you do that and maybe even go really far. You're like, I'm a DNS person. If you lack the ability to question that stuff, like you could have a very successful career. You're going to hit a stopgap of how good of a, like you said, an excellent clinician. You're going to be, you will never be world class.
Yeah.
You'll only be as good as the people you're basically mirroring. Right.
Yeah.
So not that that's bad, right? You're going to be really good
Yeah.
with the world class. Like you have to be able to like, live with different thoughts and gray areas and challenge and
integrate a bunch of
yeah. And it's not
things,
just about like, we need somebody to create another method. I think that's not what I'm saying. It's just like thinking about stuff independently. Yeah.
I think something that is similar, that goes a long way, that people will make note of is whenever you remember a small detail of something that they mentioned to you in the first visit, maybe pertaining to their case or just relating to their family or their like or interest, something that many times if you hear them say, oh, wow, surprised you remembered that about their kid having a soccer game. Again, that goes along with just being interested in who they are and helping them. But those things can help build that relationship.
Those little details there.
And they'll come back because they like being around you.
Yeah. Part of being a good person.
Yeah.
Yeah.
I feel like mine is going to be the exact same. I mean, I really don't have anything else to add to that. I mean, that's literally
no worries.
Next one.
And
we don't all have to answer.
Yeah, that's totally fine.
If somebody kills it, go for it.
All right. Here's one that was inspired by seeing Beau treat some patients recently. So when a patient presents with a complicated history and multiple unsuccessful, you could say, interventions from other providers, what is your process for untangling the narrative and beliefs that the patient may be currently maintaining?
I think like three things. Do you address it at all? Or I guess when do you address it and care? I would be the first thing of like determine. It's like I said, you don't know some of the people that say somebody literally hurt them. You still don't know if they have a relationship with that person outside of like clinic, like they're a family friend or something. I mean, that's happened all the time. And they'll even kind of say, but that's okay, whatever. And you're like, so I don't, again, being a good person, I wouldn't bash anybody. You can bash what they're doing. So that's the same kind of concept as I might absolutely think your idea is idiotic. That doesn't mean I think you're an idiot. Those are two wildly different things because your idea is different than you as a person. You might be like, I think unicorns should, I don't know, run for Senate or something. I'm like, well, you're an idiot. No, that's not true. That idea is idiotic, right? So I think you can kind of tear down, and I'm saying tear down, that sounds negative, but like what was done, if you're like, man, that's not good, which you saw in a case the other day, I was like, that was abysmal. Like that's negligent. Well, that's all I'm saying. I never said that person's, I said that is negligent. What they did, right? I'm not saying them, and that's two different things. I'm not saying that's their whole practice, right? So I think if it's negative and this becomes the narrative they were told and you have to untangle it because of something you need to treat, right? And that's where it gets tough. We had a guy the other day, comes in, long-term patient, cervical MRI. I saw him a long time ago. I've talked about it on the podcast a long time ago, a lumbar MRI that said he was signed up for surgery 2 weeks out from seeing me. We talked to him. no repeatable findings, none of this. We have the whole chronic pain talk, canceled surgery never has, or canceled surgery never has any of that.
Mm-hmm.
He comes in, yeah, 2 bulging discs in my neck. And I'm like, I thought you'd be the last person to listen to those MRI findings. Wasn't even close on what was going on that had any relation with those cervical discs. And I'm like, but I didn't say anything about the practitioner, but I needed to say, that's not what you're dealing with. It's this. And then I explained to him how, and he was like, why didn't they say that? I was like, I don't know. So basically, I think the best way is to diffuse what they were told by not directly addressing it. Be like, does this make sense to you? And they're like, yeah. Well, everything else they were told then falls to, a logical fallacy. So that's one. And then let's say something was actually like bad, like somebody did get severely hurt or something and they didn't address it appropriately. Part of that's on you as a clinician. I mean, that's in our bylaws, right? If somebody was like severely negligent, did something wrong, I mean, you at some point you kind of say, well, hey, I'm a clinician. I have, responsibilities to the board, whether it's, reporting an MD to the medical board or chiropractor to the chiropractic board. You kind of got to be like, well, did you address this? No. Well, we don't want them to do that to somebody else. So, I mean, it's to like what level? All the way from, I'm kind of being mean here, but a dum-dum telling somebody they got, degenerative disc disease in the worst spine of their life. And you're like, oh, whatever. Like, I don't care about that anymore. Versus, you need your Achilles cut in half and you're a 14-year-old and we need surgery. And you're like, excuse me? Stuff like that. So it's the degree of the severity of what they're told. And then how much do you even need to address it for what you need to get done? Sometimes you don't need it at all. Yeah. It doesn't matter at all. And then you approach the topic and it's an absolute train wreck for you. Yeah. Especially early in your career, because you're going to try to explain way more. Yeah. And then you get yourself in trouble of, let's say it doesn't work. You go through your trial of care, you just told them what they were told is wrong. You told them something complete opposite. You go through 6-8 visits and you fail too. I guarantee they never come back because they're like, well, who was right? Obviously not you either. So you got to kind of, again, that's why you paint all the pictures. I mean, so we had a person here the other day, ended up having, there's a case up there that we'll be presenting, had a DVT, got checked out. They told her she was fine. She comes in. I was like, it doesn't seem like you do, but I can't also say you don't. I don't have a Doppler ultrasound. I was like, so I'm not going to do any of these treatments, but I was like, I don't know. I literally left it at that, but I painted all the options around it. And she like thanked me at the end. And I literally don't think I did anything for her besides like explain the scenario, what she should do next, the options. Yeah. So, and I didn't know, I'm being honest. So but I didn't tell her, hey, it's not a DVT. And then she literally went to her OB later that day and they're like, oh, it is a DVT. I would look like an idiot, so like all the options, but not, I'm going to say this and it's going to be like I'm talking about, but you have to be confident in all those options. It's not like you're like, I don't know, so it could be anything. Like, what are you saying? You're like, this is the possibilities. These are the options. Lay it all out. Yeah.
And she was definitely grateful for you taking the time to explain.
And again, sometimes you can lay out all the options. You didn't see that option that it was, or you laid it all out and they still didn't buy your spiel. Like, that's fine, but you do your best to educate to the level that you need to. That'd be my thing. Yeah. Anything to add on that?
The guy, the new patient that was earlier this week that we talked about with the shoulder, that had multiple complaints, but mostly he had been talking about the shoulder. When he described it generally across, couldn't pinpoint, but had really limited how much he was doing to the point of not working out for a long time. So I told him and tried to prove to him on tests that I said, hey, these things are going to check the integrity of your rotator cuff, your labrum, the things that you're worried about are injured. And if they don't hurt and they're fully strong, we can be pretty confident that they're not. Yeah. And they were. And so then we ended up testing things that he had complained about not being able to do. Pull-ups, push-ups, all that stuff. So we looked at them. He didn't have pain doing them. Now he was kind of weak doing it, but he hadn't done that for quite a while. So once he saw that those things were, there's no weakness here, this doesn't hurt, he doesn't have the same understanding about what those tests are as we do, but I tried to explain that to him. Yeah. That, hey, these things are not, there's no weakness here, there's no pain to be these tests. And then showed him, hey, this looks like a push-up, this looks like a pull-up. So
yeah, no, it's good. I think it's a common one, that I kind of have had experiences with in the student clinic at Parker. It's like, man, it doesn't mean that it's a bad thing. So
So I heard this the other day that Netflix, the executives at Netflix are now telling directors and producers to create what they call, oh God, what is it called? Scrolling movies and shows. So movies you would watch while you're on your phone. So they want the plot to be so, the actors are literally going to tell you, to save the world, I'm gonna have to go into space and like live on Mars for 3 months. And then the protagonist would be like, are you sure you could do that? And he'd be like, yeah, take me. Like, they literally going to tell you exactly everything. But if you watch that not being on your phone, you'd be like, this is the worst movie I've ever seen in my life, because you don't want to know everything. That's the same thing as a patient. They don't want you to tell them everything. You think they do. What you're doing is trying to set up like the biggest points, and then they come to the conclusion of like, what I was told is not right. Or, hey, what you're telling me makes sense to me, rather than we over explain, like, this test is showing that, this test is showing this test. They will, like Alex said, they will never understand that. You're trying to lay it out so they're like, oh, yeah, I totally, like, whoa, why was I thinking it was that? Or why were we working on that? Or why didn't we address this?
Kind of helping them put the dots together.
It's a good book or a good movie. You're like, oh, okay, I get it. Rather than like, hey, here it is. And then they're like, again, what if you're wrong? Well, that's not your conclusion, right? And here's the crazy thing, say you fail at care and you set it up where you have this implicit or intrinsic buy-in, right, through that storytelling, you're still going to keep people around more often, right? Because they feel like it's a partnership, because they had to work with you on, your treatment and the framework, rather than you just like, this is what we do in here. Here's your 12 visits and let's get rolling. Oh, it didn't work. That's how it goes. Sometimes you can't help everybody. I mean, that's just, and that's what a lot of places are. I mean, from MD to us to whatever. Yeah,
I like that. It's
good
partnership.
Yeah,
cool. Anything else for next one?
roll.
Let's roll.
We should have brought the button for next question. I need to go get that.
We can go grab it real quick. All right. Next question comes from the one and only, now Dr. Trent McCune.
Oh, man.
Yeah. He asks, what differences are there between how you practice in your first year and how you practice now?
So you're how many years in?
Almost 2.
So you answer it, because it's honestly probably a better question for you.
Yeah. I think it goes back to what you mentioned about like, you're going to try and practice exactly like maybe how your mentors were or what you were taught like at seminars. And I think sometimes you've got to do care, in my opinion, like almost how you would want it somewhat kind of done to you. Like he may want treatment different than how I would like treatment. I would say like the soft skills, I guess, of like just some like soft tissue, like to me goes a decent ways for the patient, which I was like I guess like my first year, I was like, I'm not going to do very much of that. We're going to do some exercise. Like we're like, this is what this clinic does. Whereas sometimes it's like, like that might be good, but you may need to do a little bit of like, I don't know, a little bit, if you want to call it stretching, or a little bit of like vibration tool, or a little bit of dry needling to a muscle just to get it to calm down, because a patient feels better afterwards. And then you get some buy-in that way, instead of being like, I'm going to get buy-in because we do things different. Because I think that still can be different, right? Because you're still controlling that case a little bit, fully, in my opinion. But you're also like, again, like it's patient dependent, right? Like what has worked in the past, what hasn't worked what hasn't worked. I think that's like my biggest thing is don't neglect like how far some of like your soft skills can actually go. That's probably one way that I think I've changed, along with also not holding myself. I said this might be like a weird way to put this, but feeling like everybody has to get better in 6 visits. That is like one thing that I think like stressed me out. Like at the beginning of my career was like 6 visits, they have to start feeling better, right? And if they don't, I'm doing something completely wrong. Whereas like me and Beau have talked about, it's like, sometimes like these things have been going on for years. So to say that you're going to like fully make a change or they're going to be completely better and 100% after 6 visits is just pretty wild.
That's what I was curious on clarifying. When you say better, do you feel like in 6 visits they need to be completely better?
Like 6 visits, like in my opinion, I was like 6 visits, they better be looking at like getting out of this office type, like spacing things out. Versus like, dude, we could be 10 visits in and it's like, hey, we're starting to make some actual change now because you've had this thing going on for so long, right? And that depends on what they're doing outside of here as well. Because that's the other piece is it's like, you feel like you should be making more progress inside the clinic, but then sometimes that comes down to like, well, what kind of person are they? Are they like doing their stuff outside of here? Or are they not? And then being like, hey, this is, if we're not going to do stuff outside of here, like this is what care is going to kind of look like. It's just going to take longer, right? Not being like, you have to be like, oh, they're not doing their stuff. Well, 6 visits, let's go ahead and start spacing you out when they're not getting any better. Or being like, hey, maybe we just need to like flip what we're doing because we have ran down that path and like we have ruled that out. Like here's the other options that, like you said, you painted a narrative and you laid those things out. So that way they're not just like caught off guard being like, well, why did we all of a sudden flip?
What about you? What's different? What's different from like for you guys early in practice versus now? He said like first year versus now, but like since you guys are a couple years, like this episode of the Farmcast is brought to you by RockTape. Use code FARM20 for 20% off their core courses at rocktape.com. It includes everything from kinesiology taping to vibration and mobility training. We use RockTape here in the clinic. We use all their tools. We've done all the training. It's all worth its weight in gold. So again, use FARM20 at rocktape.com for 20% off.
That was a big one for me. And I think patient visit average probably reflects that too. Because at the beginning, even if you looked on our dashboard on Jane, the number of visits per trial of care was lower than it is now.
Do you think, in a quick way, do you think that's your expectation of what is realistic for what they're actually dealing with, or your ability to get buy-in and all the stuff we just talked about? I'm just curious. It's probably both.
Yeah, well,
right?
Yeah, I was supposed to say it's both.
Because your buy-in is probably based on your expectation, which we've talked about a lot, is like, what do you actually think they need? Like kind of like Clay talked about, of like, get the money and the timeline out of your mind. Like, what do you think they need? That is literally your responsibility, not, well, insurance cover, what can they afford? So I read an interesting thing in Blink by Malcolm Gladwell last night. He was talking about these Harding errors. So there's this Harding test basically saying like, I see Troy walk into this room, a white guy, clean cut. I see a black male walk in, same age, could be the exact same clothes. My mind is literally doing subconscious like thinking. So let's say they both come in to buy a car, like they proved this. Car salesman will offer the same car for about $1,500 more to the black guy. Because they call him a lay down. Like they think in their mind, oh, they'll pay full price versus for whatever reason. And then this like, just white guy is going to like haggle or whatever. So we're just going to start lower. So there's all these things. I think also when you look at that kind of stuff, you start thinking in your mind like, well, I don't look at every case like that. You literally look at, well, exactly what do they need, regardless of them or me. Like Seth said, like, well, I would like this, but so I'm going to paint it to my perspective. You're giving yourself, so it's your brand, but like and that's where like if it's off brand for you, and that's a weird way to put it, like what this person wants, right? Versus maybe what they need with the mix of what I think I want to give them. And you're like, this is way off. That's where you should be like, no. Whether that's a different person in your office or altogether, you're like, this is not a fit, because it's just like, that's at the end of the day, it's your career. Your job isn't to help everybody. It's to help as many people as you can. And if that's just like somebody that drives you up the wall or something, be like, dude, why don't you go over here? Now you got to figure out a nice way to tell. It's like telling somebody they got an ugly sweater. And you're like, yeah, it's just not for me.
Yeah.
I don't know. I think that's a good, from what I've seen in you, I think your buy-in of what you think's going on with them will lead to more visits, not in a bad way for people listening, like more visits, like, yeah, like necessitated more visits. I'd say that's been the biggest change, and something we've talked about a lot of like, do you think they need more? Is this enough? Like, are they making change? Like all the stuff Seth said, but maybe just, it's been a different thing. He's like, I expect perfection, in 6. And you're like, I just think that like, that's not maybe the best thing for him. It's kind of what I think up front. You're like, oh, they've been in here for 4 visits.
Yeah.
Does that make sense? Like more of a benign altruistic thing where Seth's like, put it on him, you put it on them. Like, I don't think they should keep coming in because they might not be able to afford it or time and stuff. Like, no, I should have gotten better in 6. There's probably a little bit of both there. Yeah. But I saw Kathy Dooley put up this morning the quote by Salvador Dali of "Have no fear of perfection, you'll never reach it." That's like every patient that walks through anybody's door ever. Like, whatever your goal is, I mean, nobody is ever like, oh yeah, that's perfect. Exactly what I thought. Top tier SMA, all the functional health stuff. They left 100% better. Good luck. But that's what you're trying to do. That's what Brett says all the time, right? That's your goal. Never happens.
Yeah. I think coming to terms with that for specific kinds of patients has gotten better. Like I think of a lady who, I remember several weeks ago, I mean, such a long medical history that it was like 14 pages when we got the facts in. And if she would have walked in like the first few months that I was practicing, I think I would have felt bad for her not getting fully better, even though she's been in pain for 45 years, has all these other comorbidities. And I think we worked together for 5 visits. I would have loved to work together a lot longer than that. But now I realize, like, okay, even though she may have really liked how different this care was, she's still not going to do a lot of this stuff
that's her
outside of it.
yeah.
And it's always been a revolving door of practitioners over the years, which I would have loved to have put that to an end. And
that's kind of, if you're competitive, that will be a positive and negative sometimes. Like, oh, nobody's been able to get her to like get better from that, but also nobody's been able to like get her to do stuff. So then you're like, oh yeah, we can do it. And it's like, sometimes you gotta like see the writing on the wall and be like, okay, I'm not stereotyping, but I just literally took 3 visits, and you're like, yeah, I'm not gonna do this exercise. Or you do, and they're like, the expectation is no change. Like,
yeah. And at the end of the day, I think she kept doing one of them, and she, one of the biggest things for her was like being able to reach behind her, and she can do that now. So
it's like somebody going to the dentist that doesn't brush their teeth, and they're like, "You gonna brush your teeth now?" Sure. You're like, "Okay, see ya." Cool.
Yeah. I would have loved for her to get out and start walking every day, or doing some more than what she's doing now. But
yeah.
I think, just kind of hopefully maybe wrapping this question up, but I guess like just as of lately in the last like few months, I think you as a new clinician, like you go through waves of like you're on like a high where you're like, I'm doing really well, and then you can hit some absolute like pits where you're like, yeah, smoked, where you're like, I am a pretty terrible clinician just in general. And I think some of that is reflected just because, again, like I'm almost 2 years in, not like I have like a long-standing career to talk off of, but I've had some more complex cases that have come in because patients have referred their friends in. And they're like, yeah, this person's, been going here, 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 and here. And so what I saw at the beginning was, right, I held it on myself of like, hey, I've got 6 to 8 visits and they better be better. Versus now I have like a more complex, and like since I've seen them more, it starts just making me feel like, man, I'm not that great of a clinician because I'm not getting them better in this. And I think that like that confidence still needs to remain high, even though it's just like, to me, I don't feel like in my head originally, I was like, the better a clinician I am, the faster someone gets better. Whereas that may not be the case, right? It might be like, hey, like you might be doing fantastic because it maybe took, maybe twice as long as what you thought in your head that it was going to be, but doesn't mean that it was what they didn't need. Yeah, that's been like I think
you didn't have thoughts that you sucked, you never get better. So like,
yeah.
And there are in every profession, there are people that are like, I'm the best in the world. It's like, not for very long.
I've definitely sat in bed being like, dude, I can't believe people like show back up. I'll be 100% honest.
Oh, yeah.
Like you just sit there and you're just like, you go through your notes like we've done before, and you're like, well, they said they felt the same, worse. All right, worse, and that's 3 in a row, and you're like,
well, here, and I'll answer my quick one that builds off that. I used to think that way. Oh, they're no better. They're no better. Now it's shifted way far away. I still have that feeling of, oh, they're telling me they're no better. It's no changing. I can't figure it out. So like, this is my thing. So even when people are literally like 80% better and they're like, yeah, I'm running and doing their thing, and there are things I expected to change, right? Or like 100% was my expectation. It's not me saying, oh, I didn't get them better, because I mean, they'll tell me all day like, oh, I'm better or whatever, and I'm like, I'm not figuring out this other aspect. And that starts to like, that's where for me, it's still like, oh, I suck. It's like, why can't I get that to change? Why can't I figure this part out? Why? So like I lay out a whole narrative that I'm like, this is like bulletproof. And then I'm like, yeah, I'm going to take this medication over here. I'm like, what are you doing? And like, so like for me, it's less of what they're telling me and the pain and the feedback and more of, I expect myself to be able to figure this stuff out. And I think most people that are going to be really good in any profession, it turns into that again of like the game within the game of like, oh, it's not I saw Nick Saban the other day. It's not the result, right? It's a process. So then it's that process. Like, well, how would I get better now that people are getting better? Like a lot of people are like, yeah, I'm good. Like, and it's just not my good, So I think you just like, yeah, you have your kind of echelons. Yeah.
Love it. Yeah. Actually, quick follow-up to that discussion. When you're having that dialogue with the patient about like the setting expectations for the duration of care, what does it look like? Is it like, okay, set a game plan early on, or is it that and just kind of having those touch points along the way? Like, hey, this is where you're at. This is, figuring this out, that out. They kind of, I guess, just brief. I know we've exhausted this topic, but I just wanted to shine a light on that dialogue really briefly at the end of this question.
I always tell them, we all hopefully do somewhat the same thing, but in terms of like the prognosis visit's huge of determining what it's actually going to look like. But then every visit is prognostic. Like it's just like you're cleaning it up or you're getting farther away from knowing what's going on, which is going to happen that you're like, that's, hopefully not knowing, but you're like, hey, all those options that are unexplored or possibilities, that's what we got to refer out for, get imaging to explore those now. But like, I think second, third visit, which you guys have all heard me say before, you should be able to paint a really, really clear picture. I don't think for first visit, you can give them an idea, be like, hey, next visit, if it goes this way, it's probably going to take X, Y, Z, right? You can say that. And that's what I'm saying. Second visit, like it went this way, we can expect, now I'm going to clean that up a little bit. So maybe I'm just using an example. I'm going to say, hey, I'm going to see twice a week for 3 weeks, then I'll do 1 week, then I'll skip a week, and then I'll go to a month. Like that's very common for me to say, but I'd say it on the second visit. Say I get 6 more visits in, stuff's just not changing. Shoulder range of motion not changing. They're still having pain with the same stuff. I would hope we would all clinicians would address that point. Hey, all that stuff I said, like, I don't want to keep you in here forever, but like this thing's just not changing fast. And, I don't know if that's clear fully on me or we're not doing what we need to do at home. And then you got to get those answers. If they're like, I'm doing all my stuff at home, you're picking the wrong stuff, right? You're doing stuff and here you see massive change and then you see them coming back telling you to do the exercise. No, they're not. So you got to like, again, you're trying to figure out actually what's going on. Then you got to paint the realistic picture, right? Not the one that makes you the most money and not the one that makes you feel good. Oh, I got them out of here soon enough, but literally like, this isn't changing. Oh, this is faster. And you should also be on that. Like somebody comes in with low back pain, thinking of, our low back guy, patient sent him in. His mom sent him in. I mean, I kind of even said, this seems pretty easy. I mean, it is pretty easy. There's probably a ton of stuff to work on, but it's like, I even told him, I go, hey, 1 or 2 more visits. Like, I'm going to let you run with this stuff. Just kind of see how it goes. It'll be 4 visits. Could I see him way more? Yeah. But like, it's not, you're trying to also, I think a big thing for me is what is that person's life like? So that's a college student that's going to be going back to college and like, he's not going to come back from Auburn or every break like, hey, maybe, but like I think you're also trying to lay out such a good plan for them that they're like, I do want to come back more than you even told me. And then your job is kind of like, well, you don't need to, or if you want to, cool, or hey, I'm going to give you options around that, right? But I'm not having to force them into like, hey, I need to see you more.
Cool. Yeah. Love it. Alrighty, moving on. This is a question from Ethan Holm relating to neurodynamics. He says, if you suspect nerve irritation, what are the best strategies you use to treat the nerve and the surrounding structures without treating the nerve with sliders and tensioners? Follow up to this question, this 2-part question. When you do choose to use sliders and tensioners, in what scenarios do you use them most often? The first part.
Tough second part question.
Yeah.
I mean, that's like, yeah.
How are you treating nerves
without actually mobilizing or tensioning the nerve?
So here's how I'll answer this question. I'll let you guys take the other part. I don't think you're ever treating one thing. That's what I'm going to say. So like if we said, so we have our little rubric that we kind of think of like, oh, it's, MSK, which means like tissue, peripheral nervous system, central, and then some sort of like functional medicine overlay, or that's the biggest thing. That's how it plays. So say, now we're saying, oh, it's peripheral nerve, right? Motor, sensory, cutaneous, whatever. And they're like, that's what I'm treating. Well, first you're telling me you're just treating pain, right? So that would be a pain alleviating maneuver, all of those things, right? Because then if we ask the question of, we get to the second part of when you use sliders and tensioners, it's just like McKinsey. When do you use overpressure? When do you do end range loading to do what? Get rid of pain. Doesn't tell you why that nerve was irritated or whatever, entrapped or this, that, or the other. So this quality around it, which would be you're treating a bunch of things. Which one is the most important? Yeah, you want to get people out of pain so they don't move different and they're happy and you get buy-in and all that stuff. But then the next thing is, well, what do you do after that? Which probably leads into what are you doing to work on that nerve, which is why is it irritated in the first place?
Yeah. Yeah, I like that.
But then we have a bunch of tools. I mean, we do stuff all the time. I mean, stecco, cupping, taping. I mean, all these things. So that's, again, I sound like a commercial. When I try to teach like art of assessment, it's saying, again, I didn't have any of those tools. I mean, I didn't take, dermal traction until like 5 years ago. I didn't take, cupping wasn't near as like popular. I didn't even have cups when we opened. Like, so all these things we'd say, oh, this is what you do for peripheral nerve, like stecco, cupping, DTM, like none of that. We didn't have any of that. So like, what did you do for cutaneous nerve stuff? Well, we didn't even, I mean, as stupid as it sounds, nobody was talking, like Diane Jacobs talking about skin rolling and, dermoneuromodulation, all that stuff. It's like, what do? We did other stuff to calm it down. I didn't know it was so easy that I could just like find a cutaneous nerve. I mean, it sounds stupid. And then you're like, oh man, what, you guys were idiots back then? And we did ART and you're like, but why do we have those tools? Because you got more specific with your diagnosis. So, cutaneous nerve's irritated. You can calm down that pain. Why is it irritated? Why is that irritated? Why is that myofascial entrapment there? Complain to a functional medicine thing. They're chronically dehydrated. It's how they sit at work. It's the activity to do. And pretty soon you're not back to just like, oh, the nerve, the lateral foraminal stenosis, the postural intra-abdominal pressure. It's like all of these things at once. And then that leads right back to what we said with the treatment plan. What's the realistic expectation besides just yapping and they're out of pain? And you're like, maybe. Sometimes it is that. Yeah. Like, oh, you're out of pain. You're doing pretty good. We're not looking too specific on how you run or anything. You're like, see ya. Or it's not. And then that's why you need a lot of tools. I say need. It's good to have a lot of tools. So then when that need arises based on what you find, you're like, oh, I can do this and play around with it. But then it becomes diagnostic. I did this thing. It didn't work. Did this thing. It didn't work. Hopefully that's not your first choice to just start doing stuff to decrease pain. I mean, nightmare. That'd be my answer.
Yeah. It's a good answer.
Yeah, the biggest part of that is just not. You wouldn't necessarily even have to have neurodynamics because you're trying to address the thing that is causing that nerve irritated in the first place. Which, yeah, if you didn't have cups and you didn't have dermal traction before, you were working on the thing that led to that nerve being irritated.
Like neurodynamics when I got out of school was mainly like Butler's work, right? Like the nerve mode we did the other day with the plate, right? Like these kind of exercises to take people through these full like nerve moves, right? Radial nerves, bands, like going in these big movements. So then unless you guys want to tackle it, I'll try to answer the question of the specifics of when you use it, of tensioners, sliders could fit right back into that paradigm. What's going on? Obviously that's the diagnostic part of it. You and I have talked about this a lot, pointing at Troy here, because we kind of bring up, you've went and taken some courses where they're heavy in this, these kind of fields. My take on a lot of this stuff is, and this just, I love Michael Shacklock. I think neurodynamics becomes a dermal traction. To me, that's all it is. And when I say that's all it is, I'm not discounting it, because a lot of people say, if you don't know how to do neurodynamics at a high level, you're going to miss some opportunities to remove pain. That's my take on it. People might say I'm wrong. It's no different. And I know pure McKinseyists will try to somehow throw a knife through the internet at me. It's no different with that. You can't sell me that if you do 2 days of cobras every hour, and then when you're in the clinic, you're doing overpressure and you see them 4 times and their pain's completely abolished. And let's say it was radicular in nature and all that stuff, that's the end of care. So that tool is all encompassing for that thing. Why did they have derangement? Is it motor control? Like, why did that thing happen in the first place? And I think a lot of people just rest on, well, we don't know. So just kind of abolish the pain, normalize the stuff. It's like, I just don't think that happens. Does that make sense? So
Yeah,
I think you're using those when you find, does it need tension? Does it need sliding? How? Based on the diagnostic process that Michael Shacklock teaches, your other hands-on palpation of, does it move, the tissue glide, how's the joint move? But then you could say, well, if I'm trying to fit, when do you use that? It's no different than when do you adjust somebody? When there's a joint restriction. So when would you use a tensioner? When I think the nerve can move well enough and is not irritated enough that a tensioner is going to make it worse, and tensioning actually creates some sort of like tolerance of that nerve being stretched. So you literally can answer your own question if you play the diagnostics right. All right. And then Shacklock literally spells out very clearly when you shouldn't do those things. So like, it's kind of self-explanatory, but this is, Brett Winchester makes this point all the time. What says people are swimming in information and dying for integration or application, right? They have no clue how to use this stuff. I don't think that's a methodological issue. I don't think that's going and taking another course and learning how to do it. It's learning how to apply it within diagnostics. That's the missing thing. You're like, I don't know when to do it. You're not going to go take another neurodynamic course to figure it out, because Shacklock will tell you it is or it isn't. So when are you going to know? When it is. What are you going to do when it isn't? All the other stuff. And that's not what people want to hear, but that's the truth.
Facts right there.
Anything to add? And that makes it sound hard. It is hard. I mean, that's what we just said. You get kicked in the teeth, feel like you're an idiot, all that stuff. But it's also wouldn't be very much fun if like, we're like, I got this gold standard. If you can adjust, do neurodynamics, do McKinsey, do DNS, and there's this protocol for every little thing they come in, I literally wouldn't work. I would literally hire a bunch of like chiropractic assistants and be like, here's your protocols. I wouldn't want to do that. Same reason I don't want to do post-op PT. There might be slight nuances, but it's pretty, hey, this is what you do week 1, this is what you do week 2, so all the way up to week 12. That would be so boring. I'd pull my hair off. So,
yeah, it's exciting what we get to do. All right, next question here. Can you describe a specific clinical pivot point you took in a recent case when you had to change the direction of care or significantly progress the intervention strategy? Intervention strategy, where you had to pivot. Sorry, I'm just choked up on my words over here.
Blackjack Education. That's my little pet project with Dr. Audra Lance out of Nashville, Tennessee. And we have 2 great courses coming up for you in 2026. So we're kicking off the new year right with DNS Golf right here in Birmingham, Alabama. 2 days at the farm, 1 day at Greystone Country Club. And we have Greg Rose coming in from TPI. We have Mark Blackburn, one of the best coaches in the world. We have Brett Winchester, the legend himself, and little old me will be helping teach a little bit as well. So you can go, again, blackjackeducation.com to check that out. Also, the last weekend in January 30th through February 1st, we have Dr. Richard Ohm coming to Nashville, Tennessee for DNSB. So if you're looking to up your DNS game in 2026, the best bet in clinical education, blackjackeducation.com. I mean, is that one of your questions? So here, I mean, you've been in a lot of these cases. I don't think there should ever be major pivot. Now, a pivot that you laid out and you took it, cool. If there's like a landmine, that's like your fault. And I would hope that happens less and less. It's going to happen a lot earlier, right? Like, ooh, the worst ones are what? They go to somebody else and they find something you either said wasn't existent or you didn't even mention. That's going to be the worst things ever, right? Hey, I went to a PT. They thought it was, I needed nerve sliders. They did a nerve slider. All my pain was gone. And you had just said, well, Shacklock says we shouldn't do those up front because when something's hyper irritated, that's probably the worst thing to do for it. And you're like, son of a bitch. Stuff like that. You miss it and you didn't talk about it. But the big pivots you have to take are where you never want to. I'm thinking of like our Highlands game athlete. Like he didn't want to have surgery on his shoulder. I didn't want him to. He was trying to compete. I literally sent him for what I thought would be a non-surgical consult to rule out surgery because he was so adamant he didn't want surgery and he ended up having surgery. Yeah. So what was the pivot there?
It's like outside.
I'm still not 100% convinced he needed it. Yeah. Right. But at the same token, like he wasn't getting any better with me. That's why I sent him. So it's like, what was the option? I was going to try to get him to have some sort of pain mitigation and come back into rehab, but like that might not have worked either. So let's say we did that. I mean, it's into, what is it? Just take time off? Is it surgery? I think the big pivots are like, you think you have it all laid out. And it's like, God, this stuff's just not working.
Mm-hmm.
And that can where it's tough because you could still have all the options and like you just keep running up against it.
Yeah.
Another one. So, somebody that came in with neck, I could basically like lay her down, turn her head full range motion. She'd sit back up after every visit, range motion fucked up pain. There were a lot of pivots in there, and she threw them at me. Hey, what do you think about an epidural? Hey, what do you think about this? What do you think about that? And I'd sometimes be like, I don't think that's a good idea, and sometimes it wouldn't be. So we ended up sending her out for trigger point injections, which I told her from the beginning that's what I wanted her to try to do, conjunctively with what the Karen biggest change for her. But that took me 9-10 visits to get there because of all the other like pivots that she wanted to take. And then I wanted to create a partnership. I'm like, no, don't do it. Something like that, she wouldn't come back.
Mm-hmm.
So maybe her biggest pivot was me managing different rather than like decisions on what to do.
Yeah, which can be huge.
Yeah. Like, hey, I'm not going to say no. I'm just going to be like, okay, let's see.
Yeah. I've definitely seen you navigate that management a lot lately.
Yeah. It's been, yeah. You guys think of anything?
I have one of mine. The guy that we talked about that wanted to get the MRI on his back.
Mm-hmm.
He had, prior to seeing me, had an acute flare of discogenic low back pain after getting into a workout routine, which was probably way too hard, too much, too often. And got better, got worse, started seeing me. Got better over the course of 8 visits and was doing good, back to workouts, but was always very hypervigilant about, well, I just don't, I feel like I'm just going to tweak it again, that kind of thing. Well, he tweaks it again, picking his son up. He emailed me over the weekend about he wanted to get an MRI. And I had told him previously, we can get an MRI. This is early on in care, and it's going to show that you have a disc bulge herniation. But, there's a good chance we can treat this conservatively, which it was. We did. But for him to appease the fact that he's always kind of worried about this, but he also is like adamant, I just, want to get an image. I told him, I said, we're going to see what we expected to see on the image. We will order the image. So we order the image, shows us what we saw, what we expected to see. And then getting, he, from the beginning, said he didn't want to have an injection, didn't want to have steroid, or didn't want to have surgery, which I told him, I said, if we get that, it would be because what we're doing is not enough and we would need to do something additional, which would either be an injection or a surgical option.
Mm-hmm.
We ended up doing a steroid pack, which was helpful, prior to doing those other 2 things, but they're not completely off the table. He's doing a little bit better, but at first, I think early on, I would have been like, no, we don't need to get the image because you got better. And I know that's frustrating that you had a flare up, but like, we've shown that you can get you better again. Whereas, he's frustrated that it's happened again. He's got work stressors going on and he just wants to get the image, and there's no harm in getting the image because we're going to see what we expected to see. So we did it. And I think I'm not,
even if you didn't, learning lesson for you. So I mean, I've had images where stuff pulled up, like, oh shit, I told him it wasn't that, or I didn't, and then you're like, oh, that's a learning lesson for you of like, either be better, right, at your diagnostics, or always, again, like, leave the optionality open up of, I don't know exact without it. So I think that's something I've learned too, is like, don't be absolute, with the imaging thing. Like, oh, those imaging findings don't mean anything. Yeah. Or, oh, that's not going to be on there. Or even if that was there, that doesn't matter. So I've said a lot of stuff like that. And you got to be careful.
It could have been big enough that they just said, oh, yeah, we should do surgery on this now. And it's going to be a good outcome. Granted, I didn't want to do that at the beginning because you see that and hear that from other people that they went straight to the surgery and that wasn't necessarily the best thing. But I tell people, when I have sent people out, the 2 or 3 that have had surgery have had good outcomes because they exhausted their care, trial of care first. Yeah. So yeah, that's probably the most recent.
Let's hit Troy with a question real quick.
Yeah.
What you have?
If you could start this internship over, I mean, it could be one thing, it could be a couple things. What would you do different? Like, how would you approach the internship different?
It's a good question. How I would approach it different. I would say Probably just being more vocal in like within the treatment room itself. I know it's just kind of, I've been here to shadow before, so I know all y'all, and I've got to experience y'all with, treating patients before. But there's been times where I walk out of a patient encounter when I was like, oh man, like I'm curious about this or that. And I think it's like past experiences with other providers where I guess you're more so like conditioned almost to just be there, right?
Mm-hmm.
But this is a different experience because like y'all are different, and this is such a long-term experience for me too. So I think early on, I think as I got more, I guess, comfortable with the patients here in general too, it's when we got to have a lot of those conversations in the office, getting the nuances of neurodynamics or directional preference or different things on my mind that I, got to see y'all do. But I think early on being more direct and open with questions right off the rip rather than just, okay, let me get a feel of how this patient care goes. Because again, I was just kind of toeing the line. I don't want to like overstep, but I also want to get the most out of this experience as I can. And I know all of y'all, if I ever did anything that was like, a little bit too much, we're all adults and, we can have a discussion if that needed to happen. But I don't think I would have ever done anything that would have been quote unquote too much per se. So that would be probably my answer to.
I think that's a really good point because we purposely tell people like, hey, don't have conversations. We don't want you to talk to the patient and stuff. We don't want you to like stand in the corner sheepishly.
Yeah.
But we don't want to interrupt care, like slow somebody down. But at the same token, I think it's really beneficial sometimes if you're like, hey, why wouldn't we, or, you got to frame the questions, right? Obviously, like, would you ever look at this or what about that?
Mm-hmm.
Like, it might be something that literally just like, oh, I didn't think about that. Or I forgot, like, that was in my mind. Or also like it brings it up to the patient in a way that like it creates, that's what I've you've heard me say numerous times, like it's a better patient experience when there's a shadow intern in there because I can talk to you, feed them educational stuff as a byproduct that I would never tell them. So
it's like a win-win all across
all the time.
board.
I'll say, what, Troy, is for you. Well, kind of.
Yeah.
Like, hey, pay attention to this. And then I don't have to explain hey, this trophodema thing. And then, that patient's like, what is this? And I'm like, oh, this means this. Like, oh, it's kind of crazy. But I wasn't like, hey, see this stuff? And they're like, why you tell me this? And so there you take the high level education, which is what we've always tried to do with like YouTube, like speak on a level that like, for you would learn something, but then as a patient, they're like, oh, I still understand it. That's because they're going to get fed stuff that's either right, wrong, or this, that, or the other at that level in a clinical room outside of here. So it's like that, I think, is our responsibility, not just be like, hey, this is your muscle here and we're going to rub it. And I think that's idiotic. Yeah. I think that's a really good point. Do you guys have any questions for him? I'll hit another one if not.
Yeah. Another fun question. Okay. So Seth and I have been trying to culture Troy in the ways of cinema.
I already know. Yeah.
So what has been your favorite? Now, this is preemptive because we're going to watch a pretty fantastic movie on Saturday night, but
what do you guys watch?
So I'm told.
The Holdovers.
I've never seen. I don't know what it is.
It came out 2 years ago. My new favorite Christmas movie. But what has been your favorite movie that you've watched with us and why?
I would say Dune 2 takes the cake.
Had you seen Dune 1 before?
We were
here.
Yeah. Okay. So it was Dune 1 was a pretty slow movie building up.
Even though Dune 2 is longer though, isn't it?
Yeah, it's longer.
Yeah,
it's just more action.
It's more action packed. Yeah,
I agree.
Yeah.
But it was just good.
Not too long ago.
Yeah, they really well done.
Yeah.
What was that movie you mentioned the other day? With
which one?
It was a comedy. I'm trying to remember who was in it.
Really?
It was literally, I think it was literally yesterday.
What are we talking about?
You were talking to Bridget and you said this is something that you would like.
Ricky Stenicki.
Yes, Ricky Stenicki.
Very John Cena, Zac Efron. Who is Zac Efron's business buddy? I can't remember who it is. It's hilarious. Like, so Sloan picked it. We were just one of those, like, she's cruising through. So Sloan's notorious for just, she'll look for something to watch so long that I'm like, I don't even watch anything anymore.
45 minutes.
Yeah. So literally, she went through a couple of things. She pulled out. I was like, oh, what? Come on. Hilarious. Like, absolutely hilarious. And like, yeah. So anybody out there listening, it's a little dirty comedy, but it's funny. Log it out. So add that to your list.
That actually made it easier because I have a list and I just said, "Hey, Troy,
Yeah,
I know
just
you haven't
take
seen
off the list.
any
Yeah.
of these movies." Like,
Yeah.
Yeah,
All right.
I was definitely cultured quite a bit with movies.
I got one more question for you.
Yeah.
So we got time for anything else here. So what are, and if you want to do both or if you want to do one, so what are 1 or 2 specific things that we do here that you will either for sure implement into your practice style or change or leave out?
Okay. Implement, change, or leave
Maybe
out.
try to do one of each.
Okay.
So we get,
So similar to what Seth mentioned earlier with kind of the soft tissue side of
Mhm.
things, like at the Parker Clinic and coming out of there, I'm like, I don't need to do any soft tissue work to change the quality of the tissue or, abolish a trigger point, things like that. I could just load them up in a DNS position, move them through controlled range of motion. But it has been fascinating to not only learn more about the different options when it comes to soft tissue work, but also to see how the patient responds to it, how they enjoy it, but also just to learn about the more detailed mechanisms behind it. I know, we've gotten to nerd out a little bit on discussions about it, particularly with kind of Stecco stuff or capo stuff. But yeah, needles, literally, I've been needling Alex like crazy. That's been fun too, because I've done one needling course, haven't needled outside of that course. So when Alex asked me to needle, I was like, yeah, I got this. But it's definitely built my confidence with the needle. And I don't love needles personally, as far as like getting stuck with them or the idea of, poking other people with needles, but I definitely got comfortable with it during my time here. So that's definitely something I'll take away is doing needling.
What about something that you edit? Something you're like, I don't think I'll do that, or you would change?
Honestly, something that comes to mind is in the assessment process that a lot of, not every case, obviously, but a lot of cases y'all will do gait and then kind of like a full top tier. And I'm just not as familiar with gait in general. I've never taken like a course on gait. I know at Parker, Mary and DMAC had a lab on gait, so I got to learn a little bit from that. But honestly, when I'm there, I'm trying to pick up on things and like y'all, share some things that you're seeing. I'm like, right. Right. But I think just more practice with it before I'm like actually going to feel like I can glean from it. But as well as like just top tier itself, like I don't reckon I'll do like a full top tier, but I might at some point. I don't know. I think it will be dependent on the case, but you're definitely getting things functionally that you can address with, with the case. It's just something I hadn't done before. I would do it in, the regions that were quote unquote relevant to the symptom area, but I see why you do it. And I think gait in particular is one that I would need to gain confidence in before.
We talked about that on here.
Yeah.
It's tough.
Yeah.
It can be. Yeah.
But, and what's one way to get better at it is practicing it. So maybe I'll shift that to something that I will implement. I don't know.
I think the kind of going back to your, like we talked about like the soft tissue. One thing that kind of like changed that we've talked about is like the way our profession was before. Now a lot of people are going on the train of like movement is like more needed. And I think back to when our profession was very much just like, hey, like you're going to see as many people as possible. And one day you're going to have 5 minutes, you're going to adjust, and that's what you're going to do. But you hear people that are like getting better when they go in and they literally have just some ice, heat, a little bit of stim, and then they get adjusted. And they're like, dude, I've never felt better in my entire life. And I'm like, so there's something to that, right? Like whether you're changing just neurology of like how they're like sensing that area or whatever it is, right? So now it's like, okay, well, what can I do to use some of those things and then pair it with like world-class rehab or just the rehab they need in general to improve their strategies? Like what kind of difference could I make for that patient? Like that, I think it was like a big piece where I was like I didn't want to be like what our profession was in the past, but sometimes it's like, hey, like they were doing some things right. Like there's something you can take away from it, right? And I don't think that doing those things you're doing a disservice to the patient because you did some soft tissue or you used a little bit of like heat on something, right? I don't think that's a bad thing.
Yeah, not at all.
So yeah.
Yeah, I think another thing I'll add in that bucket too is taping. I've gotten to see y'all tape a good bit, and seeing it in a scoliosis case was interesting too. And Seth taught me how to tape a shoulder with one case, and I got to do it on a patient, and they're like, wow, they felt the difference, and then objectively there is some benefit to it as well. So that's another thing I would throw in that mix, where it's like I never expected to do, but I will walk away here definitely practicing it.
So what you're bringing up a really good point, which is a good way to tie this up since we're running out of time, is it's one thing to go take. So you could go take rock tape class. You're rock taping. I mean, you're going to walk out of that class tape all over you and feel like terrible from how much tape. It's going to be really hard to connect the dots of how impactful that is on people that aren't presenting with specific pathologies, right? People in there are like, oh yeah, tape my ankle, whatever, tape this, trying to be something, tape the scar. But then you see somebody with like an AC joint separation, you see a scoliosis case, you see an acute ankle sprain, you see somebody with lymphedema, and you're like, oh, this stuff is wildly impactful, and you're using it for a variety of reasons. So, and there's all sorts of courses out there, but same thing, like needling, right? You go take a needling course, you don't see how fast it can like decrease a trigger point, and you're like, well, I might do that first in a lot of cases, just so there's less pain and they can move better, rather than doing DNS first. And you have decision points there, seeing if it gets better, and then dry needling if it's not awesome. And then you start making decisions based on the case in front of you, rather than just like, I taught the course, they taught me it's for this. And then you're like, I don't really like sticking people, but I'm going to do it. Or I don't really like sticking people. So then you just like gravitate away from it. And pretty soon you're like, I don't dry needle, So I think seeing it in practice is huge. So I think that's a good, like I said, good way to leave it, because I mean, there's a lot of students that listen to this that are going to be seminar junkies, and then they may start editing what they're going to do or not do without any clinical experience behind that at all. And I think it's a misstep. Because you can edit, right? You're like, man, I don't know if I'll be doing gait. So my feedback on that would be, I'm not saying those things you have to do to be world class. Like, we've hedged our exam to be like, well, this is the minimum. Like, this is, not the maximum. Maximum is like, there's other things that you could always do. It's the minimum effective dose. Like, this is necessary because it is wildly important to watch somebody move really for them, right? How do you move? Because a lot of people don't even know I couldn't do that or I couldn't do this, and you can correlate changes. That's for them. The gait is like that higher order integration of everything you're trying to do on the table, but also like trying to pick out other stuff. So if we have somebody with Parkinson's or some open motor neuron lesion, those would be the nuance, and that's tough because can be nuanced up front. But you might start seeing things that you never would have seen because you never looked at it. And I think that's like, so, I always think of the Robert Lardner quote of like, what you don't look for, you won't see type deal. Like, if you don't do that part of the exam, like, well, yeah, you don't get that data. Now, you might not know what to do with that data for a really long time, but then you start seeing it and pretty soon you're like, God, when somebody has a heel whip on their, right side, there's a couple big options that I got to make sure that I'm looking for, right? Hip and turn rotation, big toe stiffness, ankle stiffness, heel eversion. You're like, then you go in, you're like, oh, then you could say, oh, look, it moves way better and they walk different. I think to me, now I feel way more confident. Like, it's good versus they get up and walk to him like, oh God, this is probably be tough. That's what I'm thinking in my head, right? A runner, like, oh, they walk the exact same. Running's probably going to be a nightmare. That's what I'm saying in my head versus like, God, that changed. Then I'm like, I could be right or wrong. But in my mind, I'm like, okay, that's a better impact. So that's how I'd want to leave this, is like, put stuff into practice or see somebody put it into practice before you're like, soft tissue.
Exactly.
Like, God, I've seen big changes, or I've seen it be effective or better experience for the person, whatever that is. I think that's a really good point all the way around. So thanks for being here. Both on the podcast and the internship.
Yeah, it's been a pleasure. It really has.
And I'm sure we'll keep in touch with Troy and hear a lot out of him and see him at all the nerdy seminars that we all go to. And outside of that, anything else? Yeah, we'll enjoy the dinner tonight.
Oh yeah.
Sound good?
Sounds great. Appreciate y'all.
Yep. See y'all next time.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.